If you're enjoying the Heath Geeks Book Club podcast, we'd appreciate if you hit the subscribe button, leave a like, rating, or review, whichever your preferred podcatcher platform allows. The Heath Geeks would like to apologize to Dr. Jen Gunter for mispronouncing her name in our discussion of the Menopause Manifesto. Again, to the listeners, it is Dr. Jen Gunter.
This episode is sponsored by Well Balanced Nutrition and 360 Health.
Welcome to the Heath Geeks Book Club podcast. Listen in as Kristen Norton and Eleanor Russell review all those great health and wellness books you've been wanting to read or you have read and want to talk about. Here's Kristen and Eleanor.
Hello, fellow book readers. I'm Eleanor, and we're in the middle of a conversation about the Menopause Manifesto by Jen Gunter, and I have another health geek here with me today.
Kristen, as always.
Well Balanced Nutrition. And then, interestingly enough, we have our producer who is a male who may have menopause, not menopause.
Right.
And he may be floating in some comments here because we've had fun as we were getting ready to continue this conversation.
Yeah, just so we know, I was warned ahead of time that this may be...
Well, this is our third week of this, so, come on. You're numb now.
Yeah, so I'm here for us guys in this conversation, but I'm on the side of you women.
Okay, good.
We also have an expert with us.
Introduce her.
We have Heath McDonald. She is a pelvic floor physical therapist. Her practice is called Relief PT. Hi, Holly.
Hi, how are you guys?
Oh, we're great.
Great. We're glad to have an expert help us navigate this whole pelvic floor health.
Yeah. And so Dr. Jen Gunter in this book focuses a couple of chapters that I think are related to the work you do, Holly, bladder health and sex. So when I look at some of the recommendations and the context, she was saying menopause doesn't occur in isolation. And it has a Venn diagram about maturity and medical risk factors and menopause being related. So there's some age-related things that are typical, maybe not normal, that happen to women as we age, and some of us experience and some of us don't. And like recurrent UTIs, incontinence, particularly stress incontinence, overactive bladder, and then problems with sex, pain with sex or discomfort or vaginal dryness.
Absolutely.
And so anyway, you probably work with women who approach you because they're having some need for your help. And we want you to tell us more about that. And I think I'm going to step back a little bit and let Kristen ask you a question or two.
Yeah, just to open things up, what is physical therapy for the pelvic floor and how did you get into this work?
So physical therapy for the pelvic floor is, in principle, just like physical therapy for everywhere else, right? You're looking at the muscles, the tendons, the fascia, how they work, whether they are strong enough, flexible enough, whether they provide the stability they need, whether they work in the right sequencing or coordination. So it's just that because it's the pelvis, it happens to, the use of those muscles is for more stability, bodily functions, core strength, things that are not necessarily thought of when you think of pelvic physical therapy.
Can I say something?
Mm-hmm. Yeah.
You've just kind of clarified what the pelvic floor is and where it's located. And, men have these things too, right?
Absolutely. Yeah. Everybody has a pelvic floor.
Everybody has a pelvic floor. And Tim was saying that maybe you don't have to wax that floor. I don't know. But
or sweep it.
One of the things that I think is fascinating is pressure differentials. And when you look at body cavities, like the thoracic cavity, you have a diaphragm that separates the respiratory chambers from the abdominal chambers. And then on the lower end, you've got this pelvic floor. So, when you sneeze or push or the amount of PSI it blows my mind. Like when we sneeze, how many PSIs you got? And just think of what's happening in that body cavity when it squeezes down to let you do these things that you do. So anyway, interested in that sometimes.
Yeah, that's exactly right. Because I think people decide, or they think when they hear about pelvic floor, they think it's really only the muscles at the bottom, but it's really everything within that abdominal cavity. And you're right, the respiratory cavity also affects the abdominal cavity. So everything from the glottis at the top, the diaphragm in the middle, and the pelvic floor at the bottom helps us control all of the pressures that we use in our trunk, and all of that influences what's happening.
Absolutely. So we get to be physicists too.
Right. And back to your question though about how I got into this work. Yeah. I started out as a massage therapist. I happened to have a client who had a lot of problems with their pelvic floor. At the time, I didn't know what that was. And they were so frustrated with the medical community. They were so frustrated, especially because they felt like their doctors wouldn't let them discuss their sexual function. They had, urinary problems. They had stooling problems. They couldn't figure out what the connection was.
You mean they were dismissed by a patriarchal medical society?
Absolutely. And this was a man. But yeah, you're not allowed to talk about that kind of stuff. And massage therapy helped a little bit. But then later, when I was in physical therapy school, I heard about pelvic floor therapy and I thought, oh my gosh, that is what that guy had. He was no longer a client of mine, but and the more I asked about it, the more I got told, oh, that's something that you talk about later. We don't even address that in PT school. That's a specialty that you have to go to. The more questions I had, the more
I did not know that.
And it really set the stage for me to find out more about it, because I just felt like it was a really underserved group of people. And then once I started getting education about it, once I started really diving into that specialty, it's not an underserved little group of people. It's a huge group of people that are not being addressed. And one of my passions is women who are in their 40s and 50s currently going through perimenopause and menopause, because a lot of these issues started earlier than that, like way earlier than that. And pelvic floor therapy wasn't even available at that time. So they've been living with it and owning these symptoms for 10, 20 years, thinking there's nothing they can do. So great that that's a little different, but those are people that really, again, underserved, need information.
Yeah, I feel like many people don't realize that there is a therapist out there like you that can help with these things. Right. Without necessarily having to go to medication. So what are some of the benefits of working with you for women in their 40s or 50s? What are some of the problems that really benefit from physical therapy?
Well, can we take the urinary ones first?
Yeah.
And then the sexual ones, tease them out a little bit?
Okay. Starting with urinary incontinence.
Yeah.
So stress urinary incontinence, but also like the overactive bladder issues. So the pelvic floor and the bladder are neurologically connected and very proximal to each other. And so there's a lot of things that are integrated between those two things. A lot of times addressing one will significantly impact and improve the other. So that really helps with a lot of things between pelvic floor muscles and how they work, and the bladder and how it works. And so you can influence them back and forth, which is awesome.
That's cool.
Yeah, I notice on TV a whole lot more ads for these special underwear, and it seems like more and more education to the general public about, hey, some women have some problems, but you don't hear about, like Kristen was saying, about your specialty. And I was not clear that it was a specialty after you got your physical therapy. Is that what you said? You did additional work? Mm-hmm. So that makes you, even more educated than, wow, that's great.
Yeah. So the incontinence industry is like a $75 billion industry. Mm-hmm. They are not invested in getting you to stop being incontinent.
Right. They're going to accept it as that's a way of life.
And they've promoted that for a number of years. I mean, I remember not that long ago, I was listening to a comedian, and the comedian at the end of his whole spiel spiel said, yeah, so I'm hoping that maybe, you peed yourself a little bit today, because it was that funny thing that, if you laugh too hard, you pee yourself.
Yeah.
And, and that just doesn't, in most cases, that just doesn't have to happen. It's just that people don't know what to do differently in order to keep that from happening.
Well, hopefully our little podcast is going to inform some people. So let's keep talking.
Yeah. So I'm curious, how long does physical therapy take to see? How long do you have to do the physical therapy to see an improvement in the stress incontinence?
Yeah, and that's a really good question. Unfortunately, it depends. How long has it been going on? How good body awareness do you have? Where do we have to start? I can say that typically, if you should be seeing some kind of change, some kind of moving the needle in 3 to 5 visits. But it can take much longer than that to really completely resolve the situation, depending on, like I said, all of the different factors, right? We take a look at what are the factors contributing. Is it pressure? Is it muscle strength? Is it muscle flexibility? Is it that you can't get the coordination right? Is it body awareness? Is it tissue flexibility? I mean, there's a lot of things. So when you by the time they come to see me, it usually isn't the first time they ever have a problem with incontinence, right? It's been going on for a while, because you don't immediately leak one time and go, I know, I'm going to go to a pelvic floor therapist.
Although it's not a bad idea.
But by the time they come see me, there are usually multiple factors.
Yeah.
Just kind of depends.
So follow-up question on that, and I know Eleanor has another one.
Yeah.
So, but how do you know if it's like what amount of leakage is normal, right? Like there's all these jokes, like women working out or women sneezing. Oh, we leaked a little bit. Yeah. So I think we're conditioned to like, oh, that's just normal.
Yeah, absolutely. We are conditioned to think that's just normal. I think like any leaking is not considered normal.
Okay, perfect.
Well, that made me think of another question, but the one I had earlier was back to Jen Gunter. She was saying there are effective treatments for overactive bladder that include diet, medications, this therapy that we're talking about, and surgery. So do you work in the context of all those modalities or refer or not?
Yes. So it sort of depends on how long it's been going on and the severity of it. In most cases, I would say that a conservative trial, just like if you had to have knee replacement, right? They're not going to immediately go to knee replacement. They're going to try PT first.
Good.
I would definitely try PT first as a conservative treatment. I would say that I have a really good track record with urinary incontinence. And so I don't know personally of a situation where I have needed to go back and refer for surgery. Although there are some other steps with medication that are helpful. And typically the medication that is most helpful is not been the medication that they use for overactive bladder, but it has been like a topical local estrogen to help the tissue. So when you go through menopause, you lose a lot of estrogen in the tissue surrounding that area because your ovaries are not making estrogen anymore. And so that lack of estrogen changes the tissue flexibility in that area. And so sometimes just that tissue flexibility, if your muscle isn't well used it through its range of motion, kind of it gets stuck. So sometimes that extra estrogen, just topical estrogen, can help unstick the tissue so that we can get the muscle moving again. I have seen that as beneficial.
What about timing, avoiding, and stuff like that? Is that training or what they call bladder training?
Right. And yes, it depends on what's going on, but absolutely there are times when bladder training is important. And, sometimes it's like central nervous system is so agitated or irritated that, that your sympathetic nervous system is on guard and that's creating signals that aren't even really accurate about what's going on with your bladder.
Is that the kind of thing that wakes you up in the middle of the night and says, I have to pee? Or is that separate?
Maybe. It might be.
So, real quick question here. I actually take trospium. Is that what it is? And they said it was because of an overactive bladder. And mine's not the overnight thing. Mine's if I can be sitting in my office and I gotta go right now because it's not stopping. And I mean, I'm not going to say there's not been a little bit of leakage, but yeah. I don't know why I had to share that, but it was part of the conversation.
Yeah. But it happens to others than just women.
And I have some follow-up questions, which I probably shouldn't ask right here on the podcast. But yes, pelvic floor therapy can significantly improve that. I can't sit here without having done an assessment and say, oh yeah, I think we can get you off of it. But I think that can certainly bring the circumstances down significantly, and it's very possible to get you to a level where you don't feel like you need the medication.
Yeah. So, and to be fair, we're going to try this for just a little bit. It wasn't you're on this from now on. But
did they offer you physical therapy first?
No.
See, that's what I'm saying. The physicians could maybe say we have options here before we move to the pharmaceutical.
I think it was we're trying to figure out what it is.
Yeah.
And referrals for men are even significantly less common than referrals for women.
Yeah, wow. We love our guys.
Yeah, well, because we still haven't figured out exactly what the problem is. We thought it was one thing, turned out it was not. So, and it's not something that's like dominating my life. It's just,
right.
Hey, we need to see about this. Why am I having to go so much?
If an assessment could help you determine whether it's pelvic floor therapy, whether your prostate is irritated, whether it has to do with the how you're using your core or how you're using your pelvis or how you're moving is causing some irritation there. If it's that simple, why not go ahead and eliminate that as a possibility?
Yeah, true.
So are there things that irritate the bladder? They say maybe there are some foods for urinary tract infections, like cranberry juice and stuff like that. But the other thing is how much water should we drink a day? Everybody's telling us to drink, 60 half our body weight in ounces.
Yeah, or the 8 cups a day.
Yeah. So
it's a lot I would say
that those guidelines they're a little bit arbitrary in how they were originally determined. However, they're not horrible. It's not like, oh my gosh, this is totally wrong.
Right.
So I think that something that people do mistakenly do is feel like, okay, if I'm leaking, if I just drink less, I will have less opportunity to leak. And it does actually cause your urine to be much more concentrated, which is more likely to irritate the lining in the bladder. And so it works in reverse.
Good to know, folks.
So she has the author has some recommendations in here, and I just have to read this. It's so funny.
Go ahead.
So you said the incontinence business was big, right? There's a big industry for that. So there's wipes, feminine hygiene wipes, and this was just a moment of the author going off on the patriarchy. She says, if wipes were about genital hygiene and not oppressing women, then there would be shelves of these products for men with scents such as Dick's Delight, Sunset Escape, and Puppy Paws. So she warns against using wipes, that they're not great, and that it's just an obsession of the patriarchal society and degrading women based on their normal bodies.
Yep.
Well, yeah, in one of her podcasts, she talks about going to buy their hygiene products, feminine hygiene. So, well, why are there anal hygiene aisles, But we have our own special. Yeah, we have our own special aisle. But anyway, so we're going to run out of time, and this is really fun to talk about. But what about Botox, botulism injections? Do you like that idea?
In certain circumstances, that has been helpful. You got to keep in mind that botulism, it really paralyzes the muscle. And so we need those muscles to help us control those functions. So I feel like it's better to be, if at all possible, to try to work on training, getting better body awareness, getting better control from the inside. But in rare cases, it has been helpful to try to get some relaxation of those muscles because they're just way too rigid. But that's not the norm.
And what about weight, like obesity or pregnancy weight? Because I know a lot of women post-pregnancy, they've been traumatized. Their pelvic floor is traumatized to some level, and maybe even injured by surgical incisions and things like that. So do you see many of those? Is there a relationship of the body weight stressing the floor?
Well, I mean, I can't say there's completely no relationship. It has to do with the same things that we were talking about with pressure, right? Pressure in the respiratory cavity, pressure in the abdominal cavity. However, if that person is carrying around that weight and physically moving, then at least some of their muscles that attach to their back, hips, are still strong enough to move with them. So I think that pelvic floor should be able to become strong enough to do things as well.
Cool.
Yeah.
What about pain?
Okay, so that's a really open subject. Like pelvic pain in general, like so chronic pelvic pain during sex, pain with urination, pain with defecation, all of the above, tailbone pain.
All of the above. I think that's another area that we're like, oh, that's just normal part of aging.
Yeah. So I hate to hear people say that. That's not, I would say, not one of the things I hear most commonly, that they were just like, oh, it's common to have pelvic pain.
True.
But it's the same principles as it would be if you had hip pain or if you had knee pain or if you had shoulder pain. Wouldn't you see what you could do about that?
Right.
Probably going to physical therapy would be one of the first, most conservative things to address, any of those pains. And certainly any kind of pain in the pelvis would be the same.
Got it. Eleanor, did you have more on that topic to ask?
Well, that kind of covered it quickly.
Yeah.
Yeah, I was like, no, that did it, actually. Pain is one of those pathways that's pretty interesting. I think it's a 3-neuron pathway, and it stops up in the thalamus, and then it goes into the cortex. You've got to go to the spinal cord, and then a neuron travels up to the brain centers and then to the cortex, and you go, oh, I perceive pain. So when you're intervening with the pain pathway, you got a couple of places you need to check.
Well, so my question is, pain itself is an indicator that something's not right.
Listen to your body. You hear that one, don't you?
Pain is an indicator that your brain is perceiving a threat. Okay. That is not the same thing as tissue damage.
Okay.
Interesting.
That makes sense.
Right.
Okay.
Did you want to talk anything about the chapter on sex here with her?
Well, that's kind of why I brought up pain.
Yeah.
Pain with sex is one of those things.
Yeah. So in relative to menopause in particular, that's something that can come up during menopause, which didn't come up prior to that, right? Like if you might not have had any pain with sex in your earlier years, and then all of a sudden you're having painful sex, which is a different situation than if someone has pain during sex kind of from onset.
Oh, that's a good point. Mm-hmm.
Which also happens, right? Like it could happen either way, or you might have pain only after you deliver, right? But in many cases, women have pain during menopause, have painful sex because the tissue is not as elastic as it once was. And there are, things that we can do from a physical therapy standpoint to try to help that tissue be more elastic. I did also mention estrogen, which in some cases is helpful to help that tissue be more elastic. And then like knowing what to do and how to address it, and also vaginal dryness, which can create pain during sex, and what to do about that.
Yeah, and actually Dr. Gunter in her book has some wonderful charts at the end of the chapter or end of the book, comparing all those creams and topicals and injectables and oral and compounded versus pharmaceutical. Really interesting discussion on that. But there were some funny things in that book. But the one thing she didn't recommend that I don't remember seeing in there was get a sex therapist, because, the sexual response is very complicated. And there, this idea of, if you've had a painful experience, then you get the fear idea in your head. And then you also, that interferes with the ideation and the desire and the, ability to coordinate the function and then resolve it. So,
well, she doesn't call it a sex therapist, but she does say cognitive behavioral therapy.
I know, but
that's not the same thing.
It's not.
No?
No.
Okay.
Yeah.
It's not the same thing.
Yeah, you agree with me, Holly.
I agree with you. It's not the same thing. And I think, again, it comes to the fact that like it can be really difficult. I think this is one of the reasons that physicians don't necessarily refer to pelvic floor therapy, is that they're not even sure they have them in their area. Right. I think that's the same thing with sexual therapists, is they're not even sure they have therapists in the area that they can, confidently refer to their patients to.
I want to quote something out of another book that we read, Your Body in Balance by Dr. Barnard. He says, inventing diseases to sell drugs. He says, so-and-so points out that the pharmaceutical industry has managed to turn natural changes in libido into a disease demanding a treatment. And then he goes on and develops that idea about hypoactive sexual desire disorder and requiring testosterone patches for women. And Dr. Gunter is very, very concerned about testosterone applications. Seems to think that's not a good idea. So where you get this disease that's got to be cured, it gets to be complicated, whether it's a natural phase and adjustments that people make. So I think your area of expertise is critical for many women, and we're so happy that you had some time to talk to us today.
Absolutely. I think it's really important that we, as women, know that, pain is a signal we need help, and incontinence is not something that we
don't
have to
live.
Accept.
Yeah.
That we can work with a therapist to improve. So
maybe you'll come back another time. This was a fun conversation.
Yeah, that's right.
I'd love to.
Do you want to tell our listeners how they can get in touch with you?
Yes, please.
So, yes, my clinic is in Winston-Salem, North Carolina, and you can contact me through my website, might be the easiest, at reliefpt.com, or you can check me on social media. It's Relief Physical Therapy on Facebook, Instagram, and I've even got some stuff on TikTok. So.
Holly, we have some international listeners, and I'm not sure what their countries offer. Are there professional societies of you guys that they might tap into?
That's a good question. Internationally, let me think. Probably your best bet would be to look up Pelvic Guru or Pelvic Sanity. Both of those agencies have international reach.
And would that be true also in other states in the United States?
Yeah.
Okay. Because this is more and more of you are learning how to do this. Is that correct?
Yes. There was a bit of a bottleneck for a while in terms of getting into the classes that were available. And actually, that was kind of a bonus to COVID, because once COVID happened, they figured out how to provide a lot of this stuff virtually and online. And so more people are getting education now than ever before in terms of pelvic floor therapy.
Oh, and I'm big on prevention, which I forgot to ask you a question about. So you said before it gets to be a problem, there are things we could do. So as younger women, what are your suggestions for prevention of development of these things?
So I think that a lot of it has to do with body awareness and being willing to or noticing if something doesn't seem like it's going exactly like expected from a very young age. Like times when pelvic floor issues seem to crop up are like young teens who are very athletic can wind up having urinary incontinence issues and problems, which is an indicator of a pelvic floor problem. If their first sexual experiences are painful or uncomfortable, that's another time that maybe that they're showing that there's a pelvic floor issue. And then certainly during pregnancy, postpartum would be a time when pelvic floor issues can show up. So if at any of those times something just doesn't seem right and you're having any issue with sexual function, with peeing and with pooping, then that would be a time to get more information and check your body awareness. Like it's not all about strength. I think I've had people come in and tell me, "Oh, I've been doing my Kegels."
Well, that's what I was going to say. Would you recommend the Kegels
and
as
like,
a prevention?
100 Kegels a day. Good gosh, do not do 100 Kegels a day. Because pelvic, like muscle strength in general, is only one component, right? So it might not be strength that's causing the problem. It might be flexibility. It might be a coordination issue. It might be a pressure problem. It might be a neurological. It just depends. And so notice if there's an issue, but don't I think that that's a really common thing, is that they hear it even from their OBs and stuff. Just do more Kegels, as if that's going to fix everything. And it really doesn't.
Well, should you do them at all, or don't worry about it? Do you advocate for Kegels or not?
Like a blanket subject. I mean, again, it's hard to say. I would say that immediately after childbirth might be a time that you could do gentle Kegels, and it would be sort of universally appropriate. But for the most part, it really just depends on the person.
So I don't have to feel bad if I haven't done them for 5 years. Okay.
No, because you're not having symptoms. No,
it's not necessarily the solution, and it could make some things worse, right?
Absolutely, absolutely.
Oh, okay. So I'm glad I asked that.
If you feel like it's not helping, if you're doing Kegels and you feel like it's not helping, or if it's making things worse, then please stop and get some help. Get somebody to help you sort out what exactly is the problem.
Get an assessment from a physical therapist that specializes in pelvic floor. Yeah.
And Holly is the one in our area. Or is one? I guess there are more than one of you all here, but we know you, so there you go. And Kristen, you want to tell us how we get in touch with you?
Yeah, I'm Kristen Norton, one of the registered dietitians at Well Balanced Nutrition. You can visit us at wellbalancednutrition.com and set up a free clarity call if you're interested in nutrition coaching. And
I'm Eleanor Russell with 360 Health, affiliated with a company that actually sells supplements. So we'll have a controversial conversation about that, I'm sure. But I help people make selections when they're deficient in certain nutrients and selecting lifestyles that support good health. You can find me at 360health4u.com, and we're so happy to have been in the Podfather studio here, Such and Such Media. Is that correct?
Yep.
And Holly, again, thank you for your time, and we hope you will join us again.
Thank you so much, Holly.
The views and opinions stated in this podcast are solely those of the contributors and are not necessarily those of our distributors or hosting company. This podcast is copyrighted, and no part can be reproduced without the express written consent of Kristen and Eleanor.